Hello, and welcome to day 2 of our program on how to understand and cover rare diseases. I'm Chris Adams, Director of Training for the National Press Foundation, coming to you from the Evelyn Y. Davis Studios in Washington, D.C. Yesterday, we had sessions helping to understand how rare diseases are seen and supported around the world. We had speakers from Ghana, Singapore, Australia, France, Canada, Italy, England, and the United States. Today, we'll be talking science and regulations with the discussions on how advances in genetics and artificial intelligence are helping diagnose rare diseases. We'll also talk about how regulators spur development of drugs for rare disorders. As I mentioned yesterday, we have both program fellows and a general audience for the program. We have time for questions in each of the sessions. Put your questions into the event Q&A, and I will relay them to the speakers. For our fellows, we'll also have breakout sessions this afternoon with 3 of the speakers, Ben Solomon, Linda Goler-Blunt, and Jan LeComte. First up, though, I would like to thank our sponsor, the Paris-based Foundation Ipsen. I'd also like to share today's agenda. You can see from the agenda that we'll be moving fast from speaker to speaker. We'll hear from 3 speakers and then have a break and then hear from 3 more. After the program, we will be posting slideshows, full interactive transcripts, session videos, and extensive resources for each of the speakers. Our speakers today are, for this first block this morning, we have Melissa Haendel. She's the Chief Research Informatics Officer at the University of Colorado Anschutz Medical School and Director of the National Center for Data to Health, part of the U.S. National Institutes of Health. Then we have Suyash Sringapure, a senior scientist and statistical geneticist at 23andMe, where he's developing machine learning and statistical methods for analyzing 23andMe's large genomic and phenotypic dataset. Then we have Dr. Ben Solomon, the clinical director of the National Human Genome Research Institute at the U.S. National Institutes of Health. He previously worked for the Innova Translational Medicine Institute and GeneDx, a genetics genomics diagnostic company. Well, let's jump right in with Dr. Melissa Haendel. Dr. Haendel, thank you very much for taking the time to come speak with our fellows. I've asked her to come talk about getting an accurate count on the number of rare diseases out there and what the research shows. And so we have her for 30 minutes. She's going to present, and then we'll have time for questions. So again, welcome, and I'll turn it over to you.
Thank you very much. It's really a great pleasure to be here. I look forward to your questions and really helping get the word out about how many rare diseases there are. So why do we care about how many rare diseases there are and why? So today I'm going to talk to you about why knowing the answer to this question matters. It matters to the public, it matters to the patients, and it matters to the clinicians and scientists who aim to diagnose and help study these diseases so that we can find effective cures. So if we think about the national symbol for rare diseases is the zebra. Because the zebra's stripes are unique to each zebra. And when we think about rare diseases, each patient is essentially unique in their characteristics. And that makes studying them, diagnosing them, and understanding the public health impacts of rare disease patients very, very challenging. So in 1983, we had the Orphan Drug Act. The Orphan Drug Act essentially said, hey, look, we've got at least 7,000 rare diseases, and we only have 3, and in 1983, it was up to 34 therapies for these rare diseases. And so their incentive structures were put into place in order to help support more rapid development of therapies by public and private entities. And we are now up over 700 therapies. But to date, there are still 95% of all rare diseases do not have a single FDA-approved drug treatment. Also, a little bit by the numbers. So in the US, 1 in 10 Americans is thought to potentially have a rare disease, with 30 million Americans in the United States and 400 million globally that are affected by a rare disease. Now, these definitions still go by the same numbers that we had back in 1983 of approximately 7,000 rare diseases. And what I'm going to talk to you today is how that number is actually quite wrong. and why we need to kind of think about how we count rare diseases differently so that we can actually understand rare diseases differently. And I also should mention that as you've heard and will hear throughout the day today, that approximately 80% of rare diseases have some identified genetic origin. Also, 50% of people affected by rare diseases are children. And in the case of children, there's often the case that if we can identify an intervention or a therapy, that child might grow up to have a normal life. So it's really imperative that we count the number of rare diseases, that we can identify and count the number of rare disease patients, and that we can identify them as early as possible during their lifespan in order to define what an effective treatment strategy might be. So why the number of rare diseases is hard to determine and is not 7,000. So first of all, we do not have the same criteria for what rare means around the world. Each country defines rare diseases differently. So in the 1983 Orphan Drug Act, a rare disease was defined as affecting fewer than 200,000 people in the United States. In 2000, the European Union considered a rare disease to be rare when it affects fewer than 1 in 2,000 people. And if you look across the world, you'll find a number of other varying definitions. So what rare actually means something different in different countries. We also add new diseases all the time. We identify them, but we don't ever update the number. The fact that new rare diseases are discovered every week by organizations such as the Undiagnosed Disease Network in the United States and many other similar programs throughout the world, and that number that we list on all of our various websites still stays around 7,000, even though that was back in 1983. So we know that between the literature, all these public databases, diagnosis programs such as the Undiagnosed Disease Network, and just strategies for matching N of ones or individuals that are the only known instance of their rare disease. By finding the second instance, we thereby define a new rare disease. So in all of these cases, we're constantly finding new rare diseases, but we are not updating the numbers as we go along. One of the problems is that we don't define or identify rare diseases in the same way either. So dozens of terminologies and disease registries exist. Each has their own identifier system or strategy for describing them or lack thereof. Rare diseases are often not included in standard clinical terminologies such as the International Classification of Diseases. So if I go to my local electronic health record system for our clinic and I search for a fairly well-known rare disease, Fanconi anemia, I'm going to get back that we don't know the answer to that question about how many patients there are because Fanconi anemia is not in the International Classification of Diseases. Similarly, if I go into my electronic health record and say, how many undiagnosed patients do we have? We can't actually answer that question either because we have to provide a diagnosis for all patients. So just simply determining how many rare disease patients we have in any given clinic is very challenging. We fundamentally need to define rare diseases and model them computationally in such a way that they can work in these different kinds of contexts and around the world. And it has to date really been more of an art than a science in how we define and describe rare diseases, which really prevents the world having a shared set of definitions that can be used in a computational way in electronic health record systems, public databases, and other public health initiatives. So why do we care about how many rare diseases there are? Well, not having these clear definitions of rare diseases makes it very hard to diagnose people and develop therapies for them. And despite having 10% of the population potentially having a rare disease, the inability to count them underlies an inability to identify them in the first place. It's not the count that we care about. It's the fact that because we can't count them, it's an indication of our inability to understand them and define them, to diagnose them, to treat them. And so we must really work towards these common strategies around the world that can help us understand and define them so that we can diagnose them and find underlying mechanisms and treatments that will help improve the lives of these patients. Finally, clinical information systems, as I mentioned, really fail to fully support diagnosis and care for rare disease patients and don't help clinicians enough. So I'm going to talk a little bit about that problem. So each rare disease is really a model that's defined by a variety of different disease attributes. So if we think about a rare disease in the middle, that disease is really defined by a set of things such as variations in the genome, the D to V element on the upper left, which is a variant in a gene. Those diseases are characterized by symptoms and findings, such as and indicated there by the phenotype P. And those phenotypes have specific onsets. So disease progression is really important in how we describe the disease progression. Is it an early onset childhood disease, or is it a later onset adult disease? Those diseases are also defined by heritability, by exposures. So some rare diseases are purely the result of occupational or other environmental exposures, or can be exacerbated by specific exposures, such as the case of ethanol in Fanconi anemia. And then finally, rare diseases can often be described, or any diseases can often be described by what treatments actually work to help ameliorate those symptoms. And so if we think about rare diseases as being defined as this sort of plethora of things that characterize a canonical model of a disease, as well as the specific patient sitting right in front of you, we start to get towards a better global understanding of how we're defining the actual rare diseases, rather than just having a name and a short description. And this is a computational model that, if realized across the different systems, would really help address the problems that I mentioned earlier. So matching and diagnosing patients requires fuzzy matching of phenotypes. And this is, I'm not going to talk about it today, but this is what our international program, the Monarch Initiative, really focuses on, is how do we leverage all those disease attributes to identify how we match and diagnose patients based upon their zebra stripes. So in this example, each rare disease patient is a zebra with their own stripes, and each clinician has the challenge of identifying how to match the patient sitting in front of them with a known rare disease, but for one for which they may never have ever seen a patient like that before. And so we absolutely have to develop computational methods and data sharing and knowledge sharing infrastructure to help clinicians around the world diagnose each rare disease patient as they encounter them, and share the information about that patient so that we can diagnose the next patient. And so this diagram just tries to illustrate the fact that the goal of the clinician is to try to match patients against each other and against those known disease models that I showed you on the previous slide. So again, we think about the individual patient, and here we have a patient with a collagen 6A1 mutation. So again, that's one of those features that's related to the disease definition. And here it's a 14-year-old boy. It's a male. Obviously, it's a boy. And this patient has a peripheral neuropathy as one of the symptoms that the patient has. And so this patient eventually gets matched to a known disease definition shown on the right, which is a generalized reference model that I showed you before. So if we think about the variants and the phenotypic features, we can actually match this patient to Bethlem myopathy, which is a known defined rare disease. And so this is the task of the clinician and all the computational tools that we provide to help the clinician make those types of diagnoses. And then also those data are fundamentally utilized by drug discovery systems for drug repurposing and drug development. And so my point here, and this is part of the Global Alliance for Genomics and Health, is that we've developed a standard called phenopackets, which allows in a de-identified manner to share this very high level but very specific information about the individual patients worldwide in an open manner, so that we can collect all the specific attributes of each individual, which again, remember, they're zebras. Each one is a little bit different. And because there's so few of them, we need to know the particulars of each individual patient in order to help make those canonical disease definitions that are then used by the computational systems and the clinicians to help diagnose those patients.
Dr. Haendel, if you could go back to that one slide. Sorry to interrupt, but I want to ask one question about the definitions that the viewers are seeing.
Yeah.
Under these ID numbers, I can understand what ID 14-year-old boy is, but these other IDs like HP :0009830, what are these ID numbers references to?
Very good question. So, and unfortunately, we don't have too much time to talk about our diagnostic strategies, but the HP colon 7 numbers is from the human phenotype ontology, which is developed by our Monarch Initiative Consortium, which is a standard, a global standard now recommended by the ERDIC organization for characterizing the phenotypic features. So again, if you look over here at our little disease model, these P's over here are characterized by a clinical terminology called the human phenotype ontology, where terms such as peripheral neuropathy are encoded. And this phenopacket is the sort of package of the collection of information related. So you can package things about the variant, the phenotype in this package, and then share that information. Mondo, I'm going to talk about in a minute, which is our effort to collate the world's rare disease definitions into one infrastructure and working across countries and across different disease terminology resources. And these are computable resources, which is why they have these specific identifiers, so that information systems such as electronic health records and public databases can actually use them in a computational way. So one of the problems are labels for things often change in different countries or over time or by different communities. And so the use of standardized identifiers for identifying these types of knowledge, disease or phenotypic knowledge or other kinds of knowledge such as treatments, is really critical for the information systems to interoperate, because human language is subject to change and variation in ways that the specific computational models are not. And that's what the identifier handles are used. So you can think of them as handles, sort of like a web address, if you will.
All right. So sorry for the interruption, but it's
No,
going to get some clear. All right. Thanks.
Yeah,
So
that's great. That's great. Okay, so what is the most clinically useful way to define and group diseases? And this is going to get into those issues of the identifiers here in a minute. So there are many different disease terminologies and knowledge bases for cancer, rare diseases, infectious diseases, complex diseases, and Mendelian diseases, and then some. And these resources were not developed to be interoperable. They were developed for specific communities, specific clinical applications. But as we well know in the rare disease context, many rare diseases have cancer. Many rare diseases are complex. Many rare diseases are Mendelian. Many rare diseases have an infectious component or other environmental component. So fundamentally, from the rare disease perspective, we have to understand how to interoperate with the definitions that are being used in these more common disease contexts. So our community, and I really say community, it really takes a village. This is a global effort called Mondo, which means for the world, to harmonize the world's disease definitions, specifically for rare diseases. And this process started about 5 years ago, where we worked across all the different known disease resources, such as the online Mendelian Inheritance in Man, Orphanet, the NCI's National Cancer Institute's Thesaurus, and many other different resources to try to reconcile those disease definitions based on a variety of different strategies. And I won't go into the computational details, but suffice it to say that using a variety of features such as the structure of the graph, the synonyms and cross-references, and a variety of other sort of labeling schemes, we could actually come up with a strategy for bringing all these different rare disease resources together. And then we go through and we look at the low probability matches to try to figure out which terms actually mean the same thing, whether they have the same label or not. And trying to then come back, and this goes back to these, this definition of like, when we say the same label for a rare disease, do we actually mean the same things in terms of all these other features of the disease? And how do they relate to other diseases that are known to have slight variations in some of these features? And so that's really what we're trying to get after here with this Mondo effort. And a curator goes, a variety of curators from around the world go through and look at the ones that are low probability. So ones that we can't quite figure out, like, why is this broken? Why, in one case is a rare disease the same as another, and in another case it's a child class. It's a child a set of definitions. And so really trying to build a computational resource that reconciles all the different rare disease definitions from the different resources. And this has been a phenomenal effort because it really helps address those problems I mentioned in the beginning of having shared models and shared definitions for rare diseases, having shared identifiers, as you mentioned, but also having computational systems that can leverage those shared resources. So when we finished, we did a little experiment, and we looked at some of the rare disease resources that we used to reconcile all the different rare diseases. And so in this little upset plot, we looked at 5 different sources of rare disease information: the NCIT, the Disease Ontology, GARD, Orphanet, and OMIM. And that's just 5 resources that had a lot of different rare disease definitions. And when we looked within our mondo resource, which includes diseases beyond rare diseases, but just looking at the rare disease ones, we not only found that there were over 10,000, and actually we think the real number is probably more around 12,000 rare disease concepts known currently. But when we looked across the different resources, we realized that for some of them, many diseases are only in one source. And then if you look across all 5 sources, only 333 of that over 10,000 different rare diseases were in all 5 sources. So this really supports the argument and the need for having the mondo resource as a mechanism to reconcile the world's rare disease definitions, so that we can actually support the computational use of all of our knowledge from around the world from these different important resources. And it's not to say that any of these resources are better or worse than each other, just simply that they've had a different focus and a different strategy for how to inventory and document rare diseases. And so this effort is really, a pan-community effort to really try to use our collective information more computationally and in a more integrated fashion. And so just a few takeaways. So to know how many rare diseases there are, we need globally shared definitions, and they need to be computational as well as human readable and useful in the clinical context. We need clinical systems to require the common set of definitions to best aid diagnosis and care. We need those ICD codes to have Fanconi anemia. We need those clinical systems to leverage the disease definitions that we're developing around the world to help help those clinicians identify the zebras that they have in front of them. And we need publicly available information about the individuals with rare diseases, because individuals vary so much, and we have so few cases that we really need to understand that variability. One of the problems in the literature, for example, is the literature often reports summary information for small cohorts of rare diseases, where you can say this many patients had this symptom, but that doesn't tell you the specific spectrum of symptoms that a given rare disease patient has. And that difference, that understanding of the individual, is something that is absolutely critical for how we build our diagnostic tools, because we take into account the distribution of those features in the model for each individual in terms of how we have our algorithms for doing the diagnosis. And so finally, the biggest takeaway is that better counting of rare diseases necessarily leads to better outcomes because of all of the underlying knowledge alignment, diagnostic tools, drug discovery, and care planning that can actually occur because we've gone through the trouble of reconciling all the rare disease definitions from around the world. And with that, I'd be happy to take some questions.
So thank you very much. Great overview. We will, if fellows or viewers, if you have questions, put them into the event Q&A, and I will translate or transfer them to Dr. Handel. But for starters, I was hoping you could give me a sense of how does this very precise information that you and researchers are building, how does that translate into practice? I mean, how does the doctor, the primary care doctor out there start to touch base with diagnostic tools so he or she can try to find the zebra when they're mostly looking for horses, and how does that vary by region? I mean, are physicians in some parts of the world better at looking for the zebras than others?
That's a lot of hard questions. So, there's a couple different strategies. So for one, we've been starting discussions with the WHO about how do we incorporate mondo into ICD-11. So my hope is that we can have a more dynamic global knowledge about rare diseases directly into the world's most commonly used disease classification. And so that's one strategy. Another strategy is really related to how information comes out of the electronic health records and gets sent to the clinical laboratories that do the diagnostic testing. So currently, and this is one of the reasons that the PhenoPackets standard was developed, was most clinicians send out either a PDF of the entire EHR record or a candidate diagnosis, and not much in between. And so what we really wanted was a strategy for sharing in a more readily shareable manner, so a de-identified manner, but specifics about the individual patient's characteristics, so that would be used computationally by the clinical labs. And so we have some clinical labs that are now evaluating how we pull that information out of the EHR. Most clinical genetics experts clinically actually work outside the electronic health record right now in order to characterize their patient and help do the whole genome or whole exome analysis for genetic diseases, because the clinical environment for electronic health records doesn't really effectively support that kind of capture yet. But that's one of the things that we've been working on with the PhenoPackets GA4GH effort. Finally, I would say that one of the great challenges that we have in the U.S. that is better in other countries, such as the Netherlands or in the UK, when you have centralized clinical data, you have the potential to identify rare diseases in a more ready fashion, because you can look across a much larger population of data that's already structured in the same way. And one of our goals in the United States is to develop resources to scan the electronic health records to try to identify rare disease patients that should have that further workup that we're missing. And unfortunately, I would say that rare disease diagnosis just takes a whole lot longer in rural and disadvantaged communities, because we don't have those, first class, clinicians that are, really adept at using those kind of external tools in those contexts. So really, I think, and that's true around the globe, but it's especially true in our U.S. setting, where our electronic health record systems are so uninteroperable.
Okay, so we have time for we have a couple of questions from our fellows here. This is from Mary Kim, a freelancer from the United States. What makes something its own disease rather than a subtype of another disease? Subtypes of cancer with genetic variants that don't respond to therapies the same way are classified the same way.
That's a very good question. And for those bird watchers in the audience, we call this the lumping and splitting problem. Essentially, those models that I showed, the features of the disease, so whether or not you have a different variant, a different gene, different treatment, different phenotypic features, different onset, different heritability, these are all different features that are used in defining whether or not a disease is a new different disease, or it's a subset, a subclass, a subtype of that disease. And what really drives some of those decisions, and we try to get experts together to make these decisions. And this is actually a really robust effort in collaboration with the ClinGen program and the Monarch Initiative around the mondo disease definitions in particular, where we really want to think about the clinical ramifications. So even if you have diseases that have exactly the same care, exactly the same phenotypic features, onset, heritability, but have the same treatment, they might still be considered the same disease, even if the variations are in different genes. Whereas you can also have diseases that have variations in the same gene that cause different phenotypic characteristics and are treated differently. And so when the clinical care is different is a primary driver of when to decide to sort of mint a new rare disease entity.
Okay, another question from Aaron Prater, a fellow of ours from the Gazette in Colorado Springs, Colorado, which is not, you're in Denver, right?
Denver, yes.
That's right, okay. So how does epigenetics affect the count of rare diseases? How should patients with multiple genetic errors be handled?
So those are two different questions. And I would say that we are still in the infancy of understanding the epigenetics in rare diseases. There's some really good science and really good examples, but how that's utilized in the context of the nomenclature for diseases and when to mint new diseases is yet to be determined. We currently try to sort of think about the environmental factors in a sort of light touch way, because really the focus has been on the genetic variants and the treatment aspects, as well as the phenotypic aspects. But this is absolutely critical for the future, not just for rare diseases, but for all diseases. And so definitely a very exciting area of research that we definitely need to include in our future. As far as how patients with multiple diseases or multiple variations should be handled, that's actually one of the great benefits of being able to share individual information, as I showed, rather than just kind of lumping people into broader categories with the PDF or candidate diagnosis. And using those sort of algorithms that leverage those ontologies, the human phenotype ontology that I mentioned, we actually are able to disentangle, and there's been some great, very large studies done on this, disentangle patients that have multiple diseases based upon the spectrum of phenotypic features that they have. So, if you have a set of features that are related to one disease and a separate set of features that are related to another disease, it can often be very hard to diagnose that patient. But by accurately describing those phenotypic features independently and then running the algorithms against the known diseases encoded in mondo, we can actually disentangle multiple diseases. And oftentimes you'll see with these patients that those phenotypic features, compound on each other and become slightly different. And so it's really relying heavily on those computational tools and that encoding of the phenotypic features to disentangle those. And it's critical for their diagnosis and their care to have that information. So.
Okay. I think this will be the last question. Is from David Wahlberg at the Wisconsin State Journal in the United States. Has the number of people known to have a rare disease ever increased enough for the condition to lose its rare designation?
Yes, although I'm hard pressed to come up with a recent example. The ability to diagnose diseases has increased enormously. We are much better at diagnosing rare diseases than we used to be. And so again, this kind of comes back to, it's actually hard to count that because when you look in the clinical record systems, you can't actually say how many patients had X rare disease even still. So even though we know the diagnosis rate, so for example, I work with the Fanconi Anemia Foundation, we know that we are diagnosing more Fanconi patients. They're still considered rare because there's a big community effort to do that. But you can't query US systems to find out if the number of diagnoses of Fanconi anemia has actually gone up. So yes and no is the answer to your question. Yes, there has been some common rare diseases that have sort of become less rare as we've diagnosed them, but it's still so hard to count that it's hard to answer that question. The other related thing to state is that some rare diseases are rare in certain contexts. So, for example, sickle cell anemia is fairly rare in the United States, but is fairly common in equatorial regions, especially in Africa. And so it's very dependent on local demographics, local clinical care, and just environmental factors, and in the case of sickle cell anemia, evolutionary pressures in certain parts of the world.
Okay, I'm going to take one more question, then we will move on to our next speaker. This question is from Ridwan Karim Dini Osman from GH1 TV in Ghana. Data is a big challenge in Africa, and this often downplays the urgency of issues. How can this be fixed from where you sit?
That's a wonderful question. And we'd love to, so I spent quite a lot of time on the sickle cell problem in Africa, actually. I think that one of the things we really need to do is to better empower patients themselves to share data. There's often a fear of sharing information, but we can design systems like the PhenoPacket system that I showed that can actually be used by patients on phones to share information, and then by sharing that information, build systems that help deliver key information back to those patients. So really kind of trying to enable the patients to be a much more active participant, even in resource challenged settings or settings where there isn't like a centralized clinical care database or these kinds of things, because worldwide, if we actually had a phenopacket for every rare disease patient, we'd be able to diagnose so many more patients, even in places like Ghana, with sort of crowdsourcing around the world to help those patients get the information and the care that they need. So I think careful data sharing can be realized by both. We talk about it usually in the context of clinical data sharing and how do we identify clinical data, but I think we often forget that patients are the best source of information about their rare diseases, and so really working much harder together around the world to help patients share data effectively, but also ethically.
Okay, and with that, I think we need to draw this session to a close. Dr. Handel, I want to thank you very much. It's been a wonderful talk, and I'm glad we get these extra questions in. So I want to thank you very much, and fellows, you'll be getting contact information, so it's always possible to try to contact these speakers down the road.